Hi, my name is Lauren, and alongside Kelly D, Kelly L, and Sadisha, I welcome you to our presentation on endometrial carcinoma. Endometrial carcinoma is a form of cancer where malignant cells develop in a female's endometrial tissue. This is very prevalent in society, being the fifth most common cancer, as well as the most common gynecological malignancy in Western countries. EC is a global issue with an incident rate of 320,000 people diagnosed each year and causing 7,600 deaths. In Australia alone, approximately 2,500 new cases are diagnosed annually with a death toll of 350. Endometrial carcinoma can be classified into two subtypes, with the most common subtype, type 1, mainly endometrioid adenocarcinomas, accounting for 90% of all cases. This type is generally low grade with a good prognosis of an 85% 5-year survival rate. Type 2 endometrial carcinoma, predominantly found in older women, carries a much higher grade and poorer prognosis of 58% 5-year survival rate. Including clear cell serous-papillary subtypes and carcinosarcomas, type 2 is not confined to the uterus with deep myometrial invasion and high risk of extrauterine disease. It is common for this cancer to arise from endometrial hyperplasia. Infertility, nulliparity, early age of menarche, and late age of menopause are all high risk factors for endometrial hyperplasia development, which may later develop into EC. Unopposed estrogen exposure through hormone replacement therapies, as well as conditions such as polycystic ovarian syndrome, is associated with an 8-fold increase of EC. Other risk factors include a history of type 2 diabetes, hypertension, breast cancer and subsequent tamoxifen use, obesity, and Lynch syndrome. The main symptom identified in up to 90% of cases is abnormal uterine bleeding. Also very common is abnormal vaginal discharge, which is found in 80% of women diagnosed. Other signs and symptoms include pelvic pain, dyspareunia, or patients can be asymptomatic.
Like Lauren stated, vaginal bleeding is the most common symptom that initiates the ultrasound scan for diagnosis. Ultrasound is used to look for thickened endometrium, endometrial fluid, abnormal vascularity, which are clinical indications associated with an increased risk of endometrial carcinoma. Typically, the sonographic appearance of EC presents as a thickening of the endometrium measured in the longitudinal plane. However, further scans of various other modalities, as well as biopsies, are generally required to confirm a diagnosis. There is a high chance of endometrial carcinoma with increasing thickness. Given that they're at the menopausal age and not on hormone therapy, 4 to 5 millimeters is the cutoff indicative of carcinoma. The cutoff increases to greater than 8 millimeters for patients receiving hormone therapy. In premenopausal women, the endometrial thickness depends on what day of the menstrual cycle they are at. As you can see on figure 3, the endometrium can also appear with a mass-like appearance, and the uterus may also appear enlarged and bulky. Figure 4 on the right demonstrates diffuse infiltration of the myometrium. As you can see, it can be difficult to differentiate between textures and layers. The endometrial carcinoma and myometrium share similar echogenicity and echotexture in this example. Figure 5, images A and B show a normal transvaginal ultrasound scan on the uterus in longitudinal and transverse planes. As seen, normal endometrium is thin, uniform in echogenicity, and has a hyperechoic halo. The halo is seen between endometrium and myometrium, showing clear differentiation. In contrast, images C and D show no clear differentiation compared to normal scans. Kelly will now discuss the scanning protocols.
Before scanning a patient, the sonographer must ensure they have received a valid referral and must obtain a thorough patient history. The procedure must clearly be explained, including risks versus benefits, before informed consent is obtained. Hygiene and infection control should be practiced at all times to protect both the sonographer and the patient. Ultrasound is preferably performed on premenopausal women during the early proliferative phase when the endometrium is at its thinnest, or 5 to 10 days after the last progesterone tablet is taken for postmenopausal women on HRT. Two approaches can be used when imaging the female pelvis. A transabdominal scan is routinely performed first, with the patient in a supine position and a full urinary bladder. A low-frequency curvilinear probe is used. After warm gel is applied, the probe is placed just above the pubic symphysis and the pelvis is surveyed in both longitudinal and transverse planes, and a series of representative images are taken. The TA approach provides a good overview of the pelvis and is minimally invasive. However, it's not suitable for all patients, such as those who are unable to fill or maintain a urinary bladder. A transvaginal scan is offered next and does not require a full urinary bladder. The patient undresses from the waist down and is placed in a lithotomy position. A sterile-covered high-frequency curvilinear probe is inserted into the vaginal canal and high-resolution images are obtained. SIS is commonly used with a TV scan, which involves distending the endometrial cavity with saline to better visualize focal and diffuse conditions of the endometrium, such as EC. This approach is highly invasive and not appropriate for all patients, such as minors or those with acute pain. Written consent is required and a chaperone highly recommended, especially when a male sonographer is performing the exam. When pathology such as endometrial carcinoma is found, imaging is extended. Any focal lesions noted should be measured in 3 dimensions and the volume calculated. When diffuse endometrial thickening is seen, it should be measured from the endometrium's anterior to posterior borders in the longitudinal plane, excluding any fluid in the endometrial canal. When possible, a TA and TV scan should be done together for a complete and thorough examination. Kelly D will now talk about other diagnostic methods and potential treatments of EC.
MRI demonstrates high accuracy in pretreatment local staging of endometrial carcinoma. This results from its superior soft tissue delineation. It is effective in assessing deep myometrial invasion, cervical infiltration, and lymph node metastasis. Endometrial carcinoma lacks the uniform high signal of normal endometrium on T2 weighted MRI. Integrated PET-CT has high specificity in diagnosing metastatic disease. Dual PET MRI provides superior soft tissue contrast and diagnostic accuracy of myometrial invasion. Surgical intervention is advocated for non-invasive disease. Treatment will include abdominal hysterectomy, bilateral salpingo oophorectomy, and peritoneal washings. High-risk histology types will require pelvic and para-aortic lymphadenectomy and partial omentectomy. Progestational therapy may be used in patients aged 40 years or less wanting to preserve fertility. However, endometrial carcinoma can progress in 80% of cases with this type of treatment. Subsequent to childbearing, patients are recommended for hysterectomy. High-risk category patients are referred for post-operative chemotherapy and radiation therapy. Chemotherapy agents target metastatic disease. Vaginal brachytherapy and external beam therapy correlate to improved local control of endometrial carcinoma. The objective of management is early detection of disease relapse in the vagina, lymph nodes, pelvis, peritoneum, and lungs. Significant rates of recurrence develop in these regions, often within 3 years of completed treatment. Consequently, patients should receive evaluations at 3 to 6 month intervals. If recurrence is confined to the pelvis, patients are eligible for radiotherapy or exenteration. MRI helps assess treatment volume in radiotherapy. If extrauterine disease is present, hormonal therapy or chemotherapy is advised. Dual PET-CT is used to exclude asymptomatic metastases. Therapy can cause short-term and long-term side effects, specifically functional losses in patient behavior, life domain, and psychological distress. Urinary and fecal incontinence can also result. Accordingly, psychosocial support, physiotherapy, and pelvic floor training is offered in patient management. If malignancy is suspected, pelvic ultrasound represents the first-line imaging modality. The information we've discussed today is critical knowledge for a sonographer trainee. Thank you very much for listening to our presentation.